Good afternoon, everyone, and thank you for joining our July 2023 Telehealth Learning Collaborative hosted by the North Country Telehealth Partnership. My name is Nancy Del Mastro. I'm the Telehealth Project Manager at Adirondack Health Institute. And today we are joined by Dr. Larry Merkel, who will be talking about telepsychiatry and rural mental health. Before we jump into his presentation, just want to give a few housekeeping and updates for the group. We are recording the meeting and we will provide the recording and slides to all attendees in the next few days with the notes. For our state agency telehealth updates, just a few updates on behalf of DOH today to share. The New York State Department of Health is working on a new clarification to the Medicaid update on telehealth that they had put out earlier this year, and everyone could look out for that. It will be released in the next few weeks. In this clarification, there will be an addition on e-visits, which will be covered as of October in 2023, and they'll also be building out the off-site presence billing grid in a bit more detail. Based on some questions that DOH has received since releasing their guidance document. I'll just put a link into the chat for the DOH website's telehealth page. And again, we'll be sure to share any updates as they are available. In addition, we did receive that the news that CMS did release their calendar year 2024 physician fee schedule proposed rules. So I'll be linking that in the chat as well. There's the fact sheet and then the federal registrar page that has those proposed rule. And these are in the comment section until September. So you'll see that coming into the chat shortly. And if you have any questions, feel free to reach out, but we'll have all of the information and details on this in the notes document. And Wendy is asking in the chat if OASAS is planning on releasing any new telehealth standards. I don't believe that Kelly Grace is on the line. That's our representative from New York State OASAS, but I'll follow up with her and ensure that the notes do have the information and any stuff that we could find out from Kelly and OASAS's regulations. In addition, we just wanted to share also that our North Country Telehealth Conference, which is now the North Country Leadership Summit, will be happening this year in person. The first time we've been in person since 2019 for our conference, which is very exciting. I'll place the link to our website in the chat, but we wanted to specifically call out that we are currently looking for nominations for our North Country Telehealth Innovators. This is an award that we present to telehealth innovators in the region that are providing innovative programs or applications of telehealth throughout the North Country that leads to improved health outcomes in the community and improved quality of life. So you'll see that on our conference page. There's an application form to nominate any of your colleagues that serve the North Country and have implemented telehealth programs. And again, we'll be presenting those awards at our conference that will be hosted on the 27th and the 28th in Lake George in September. And for any more information, please reach out. We're currently finalizing our agenda and we have a lot of really awesome sessions lined up. So more to come as we continue planning. But with that, I'll turn it over to Dr. Larry Merkel to begin his presentation on telepsychiatry and rural mental health.
Thank you, Nancy. Thank you very much for inviting me to this. It's an honor for me, and I'm very glad to speak to you all about these issues. I've been doing telepsychiatry for not quite 30 years, about 28 or so. And most of that time I've been working in Southwest Virginia, a part of Central Appalachia. I took essentially a sabbatical in the 97 and went to New Zealand for a year where because they were very much ahead of us in rural mental health work. And so I learned there how to do telepsychiatry along with other kinds of mental health procedures that are techniques and such that are appropriate for rural settings. So some of that will come up today. So let me begin. Okay. I want to start off talking about the American Psychiatric Association because they've been incredibly supportive of this work that I and others in Central Appalachia are doing. And as you see here, this is the APA's position statement on telemedicine and psychiatry, and they're very supportive of it. They want to help to promote equity by increasing access to care, and therefore seeing telepsychiatry, telemedicine in psychiatry as an important part of the mental health delivery system. And by this, they mean a number of specific points that there shouldn't be a requirement for an in-person visit, that sometimes can be helpful and may be appropriate, but it's not always feasible, especially when we're working in Southwest Virginia, where it's a 5-hour or more drive to here at the clinic. And as we're going to see in a bit, these people are often in situations of poverty and have poor transportation. So asking them to come all the way to the clinic is just not always feasible. And in some situations, as the APA supports, audio only is the best that can be done and is really appropriate for many situations. I have one man I work with down in Southwest Virginia where his access to the internet or any sort of other communication is really limited. And so we primarily talk over his phone, but even that, it's very difficult. Reimbursement for telepsychiatry should be equal to in-person delivery, as the APA is urging, and that there should be able to be controlled substances prescribed given the physician's discretion about the situation, and that there should be training to help with supervision of people in remote locations. As a consequence, the APA's priorities are to support telepsychiatry through both policies and practice, such as they did during the COVID public health emergency, improve reimbursement for telepsychiatry, as we mentioned above, understand and address the effectiveness of novel technologies in telepsychiatry, which I'm sure you all are quite aware of, are expanding phenomenally and need to be understood and incorporated where appropriate. Prioritize clinical decisions in this and over any other kinds of variables, economic and otherwise, that the clinical decision is what should be take the lead in finding out the appropriate modalities and especially even the use of controlled substances and support virtual supervision. The APA does these things through policy and advocacies that all members are urged to be informed of the priorities and the clinical realities and to speak to other partners in CMS and DEA and FDA and HRSA to push forward legislation at the state and federal level for improving these situations. APA members and staff develop materials, and we'll talk about some of those coming up, to educate psychiatrists and patients and other mental health partners around telepsychiatry. And they also provide the practice management helpline, which is a one-to-one assistance to APA members in dealing with aspects of practice. I'm going to speak now specifically about how the APA has been very helpful in our efforts to try to improve mental health care in Central Appalachia. Just to give you some background, because you may or may not be very versed in Central Appalachia, this is a map showing all of Appalachia, which runs from southern New York all the way into northeastern Mississippi. And it's got three main areas. This sort of turquoise, I suppose, is northern Appalachia, and this deeper blue is southern Appalachia. And these three colors here, the purple, the yellow, and this brick color, this is all of central Appalachia. It involves all of West Virginia, southeastern Ohio, eastern Kentucky and Tennessee, western North Carolina, and southwest and western Virginia. And this is the area I'm going to be discussing. And this specifically here, this area of Virginia is where I've been working primarily, but have colleagues working in other areas of central Appalachia. Central Appalachia is predominantly white, but this is slowly changing. And you can see from this that compared to the U.S. as a whole, Central Appalachia is the whitest of these areas, with almost 90% being white. But there's a very important and proud African-American Black community in Central Appalachia, which has been there for many hundreds of years. Many of the people that Black people that originally settled in this area escaped from slavery and settled in the area, often living within the Native American population. They were also brought in during the late 1800s to work in the coal mines and have been an important aspect of this culture. They refer to themselves as Black-Appalachians or Afro-Appalachians. There's a growing percent of Hispanic population. This is the fastest growing segment of the Appalachia population. And then the others, which are primarily Native American populations. Appalachia, especially central Appalachia, is one of the poorest parts of the United States as a whole. This shows distressed counties. And the red is the most distressed counties. And you can see that within Appalachia, which is primarily very poor to begin with, central Appalachia has the most distressed counties. This is looking at other aspects of health disparities. You see the median household income for central Appalachia is a little over $34,000 compared to $56,000 for the U.S. as a whole. That the percentage of families below the poverty level is a quarter of the families in central Appalachia compared to 15% in all of the United States. Households receiving disability is almost 3 times that of the United States as a whole. It's the lowest level of education. Only less than 50% have any sort of college training. Primary care providers are very low, like 2/3 of what are found in most of the rest of the United States. Mental health providers are also very low. Infant mortality, which is a fairly good measure of general health of a population, is much higher than the United States as a whole. And years of lost potential is almost twice as much as the U.S. as a whole. The one area that's different is that this idea of social associations, the number of people that a person counts in their social network in all of Appalachia is much higher than in the U.S. as a whole, and in central Appalachia is about equal to the U.S. as a whole. And this is a strength of Appalachian populations, which we'll talk about also in a bit. This is looking at the deaths of despair, which are suicide, deaths from drug overdoses, and drugs related to alcohol use. And since 1990s, when OxyContin was first introduced into the Appalachian area as well as the United States as a whole, we can see that the deaths of despair in central Appalachia have remained above that of the U.S. as a whole and have greatly increased over the increase in the U.S. as a whole. So that we're dealing with in central Appalachia a population that's poor, that's isolated, that's in distressed counties where there's very little employment for people, and which are suffering from a large number of psychiatric and medical conditions. So there's decreased access and availability to services, not just mental health, but all services. There's some counties in Southwest Virginia that actually don't have doctors. The clinics are run by nurse practitioners, which do an excellent job. There's increased needs because of the high level of disability and substance abuse and other psychiatric concerns. They often lack insurance until Virginia expanded Medicaid a few years ago. Most of the people we dealt with in Southwest Virginia, about 90%, were indigent and had no insurance. Transportation is a huge issue. Other infrastructure needs like housing, jobs, lack of education are all critical and impact these people's health. There's strong cultural differences, which we'll talk a little bit about. And it's also an area where there's very limited research or attention paid to these populations to help us understand and deal with the barriers that they face. The APA's Division of Diversity and Health Equity has done an extremely important job at trying to reach out to marginalized communities and have been doing this for about 10 or 15 years in various ways. And in 2017, they reached out to me to focus on Appalachia, seeing that as an area that was very much in need and under-resourced. And so we held our first planning meeting at the University of Virginia at Wise, which is a satellite campus of the University of Virginia down in Southwest Virginia, in October of 2017. We then held a second meeting about 7 months later in Abington, Virginia. And at that meeting, we decided to join with East Tennessee State University, which does a yearly conference on mental health care in Eastern Tennessee. And so we expanded it to a 2-day conference where we would talk about the APA would support one day of it, and East Tennessee University would support the other day, but they would overlap and combine. And in the first day, we talked about some of the newer ideas, some of the innovative aspects that are being done to try to help with Central Appalachia. And the second day, the ETSU people focused primarily on telepsychiatry. We also then did a small presentation at the Psychiatric Services Institute meeting in October of 2018, right before the conference. These are some of the literature that we've put out with the help of the APA through the Division of Diversity and Health Equity, looking at best practices in working with Appalachian patients and on the mental health needs and disparities of Appalachian people, which are available at the APA's website. After the ETSU conference, we then immediately started planning to have another conference, to try to have a yearly or every other year conference to try to improve interest and knowledge within Central Appalachia. And we thought we should focus this time on West Virginia, since they were probably the least attending at the conference we focused on at ETSU. So we reached out first to Marshall University and held a meeting with them in Huntington and talked about possibilities there. And then a couple months later met with West Virginia, University of West Virginia in Charleston, to bring them into it and combine our efforts. We then set a tentative date for a conference in the spring of 2020. And of course, everyone knows what happened then. COVID came onto the stage, and that just took away everything, as everyone has dealt with. So our West Virginia meetings were canceled. Our own clinic moved very quickly to remote visits because we had been doing telepsychiatry for quite a while. We were able to switch over to remote visits within a matter of days, whereas many of the other clinics here at University of Virginia took months to be able to accomplish that. Our telepsychiatry visits, though, in Southwest Virginia dropped drastically because many of the remote primary care clinics either closed or went primarily virtual. Many of them had just their primary care provider working with people remotely in their homes through some sort of video or telephone connection, and had to let go many of their ancillary staff. We had started an MAT program down in Southwest Virginia near Wise after about 4 years of effort, which was going very well. And when COVID hit, though, it struggled somewhat because people did not want to come into the clinics because of potentially getting COVID. We then, our ECHO programs, which we had been doing, were then shifted to focus on COVID training in residential care facilities. So much of our efforts changed course. In January of last year, we reached out to many of our members and reestablished our efforts to work on mental health care in Central Appalachia, and named ourselves the Central Appalachia Network of Mental Health Advocates, with the APA's support, again, especially the Division of Diversity and Equity. We wanted to renew and revitalize our old connections that we had constructed before COVID happened. And as part of that, we then joined with the American Psychiatric Association's Rural Caucus in order to expand our connections. We started doing presentations at regional and national meetings, including the APA's national meeting. We want to start a social media effort, and we're looking to do that now. And in order to start building more joint research and implementation projects with our various allies in Central Appalachia. And these are the allies that we have now. Several universities, University of Virginia, East Tennessee State University, Marshall, West Virginia, University of West Virginia, East Carolina, University of Kentucky, Virginia Tech, Radford, Emory and Henry College, as well as the American Psychiatric Association. We have connections with the CDC, Appalachia Regional Commission, the Society for the Study of Psychiatry and Culture, Healthy Appalachia, which is a NGO working out of the UVA at Wise in order to improve healthcare in Appalachia as a whole, the Opioid Research Center, part of ETSU, Appalachian Substance Abuse Coalition, and the American Association for Community Psychiatry are all organizations that we've joined with to promote these efforts. I'm going to talk a little bit about some very specific telepsychiatry efforts through by our allies in order to show you some of the different models that we've developed in order to work in this setting. First, talk about the University of West Virginia. They are located here in Morgantown in northern West Virginia, and their telepsychiatry is primarily through what they call comprehensive behavioral health centers, which in Virginia we call community mental health centers. And they serve two of them primarily, one here in the far reaches of West Virginia in Weirton, and the other here in more central West Virginia in Elkins, where they provide through telepsychiatry care to the local populations that use these comprehensive behavioral health centers. The other thing that they have are providing mental health care within emergency rooms in certain areas of West Virginia. So one in here in Wheeling, and then another in Jackson, Braxton, Somerville, and then in Fairmont. And they provide, I believe, 24-hour care at these community emergency rooms, provide 24-hour mental health consultations and care. Through these efforts at their comprehensive behavioral health centers, they've treated approximately 50,000 people since they started in the summer of 21. And in the emergency room consultations, it's been over about 450 people. East Carolina University, also one of our allies, has probably the most impressive and vibrant connection. They have several programs that they developed. They started off with the NC STEP vision, which is providing emergency consultations to community hospitals throughout West Virginia, throughout North Carolina. It's a wonderful program, and it is based on state support. There are it's an item within the state budget. They set up a coordinated care situation with these emergency rooms with the state support, and have trained the health workers in these emergency rooms to do assessments of people with psychiatric or substance abuse concerns, and then they provide either immediate psychiatric consultations or through techniques such as store forward consultations on people in these emergency rooms. And the red dots are the emergency rooms that they service. And they have several hubs where they have psychiatrists working that provide the consultations. So these are not psychiatric members necessarily of the ETSU staff, but maybe private psychiatrists who provide time and get reimbursed in these settings. So it's a very neat program and mechanism that they've developed to do this. They work at 38 hospitals. 37 of them, I said, are alive, and they've seen almost 60,000 people since they started in December of 22. They've overturned almost 10,000 involuntary convictions in finding people appropriate outpatient care. And all of this has come to a savings for the state of North Carolina of $50 million. And so this money is then sort of filtered back into mental health care, such as this program. They have the 4 hubs, which I mentioned, that have 59 consultant providers that work part-time in these hubs. And 32% of their patients have no insurance, and North Carolina has not expanded Medicaid. The other program that they've developed is a community-based program where they work with primary care providers to provide consultations to them within their clinics, so either at health departments or OBGYN or primary care providers. And this is a program that's accessible to these primary care providers, and where they use evidence-based practices to help. They use team-based care. The primary care provider remains the driver and prescriber. And I'll talk about this when we talk about what we do in Virginia. It's patient-centered collaboration, and it's in order to expand the limits of behavioral health care in primary care settings. This is especially important in areas of Appalachia, like in Western North Carolina, where, as we said before, there's very small provider availability. The population health approach, they incorporate telehealth and other health technologies, and it's evidence and measured-based care. And since this started, they have 24 community-based sites, and they've seen over 15,000 patients. With about 1,700 total patient visits for a psychiatrist and 14,000 for mid-level providers. This is their newest program called the Mothers Project, which is also based on doing telehealth, where they provide at-risk mothers, pregnant women, with these various supports. So psychiatrists, primary care obstetricians, MFM specialists, certified diabetes educators, and this is a program that's also built through the state. Through this, they've seen 122 people with their MFM specialists. They have social workers and psychiatrists available, and over 1,200 mental health visits. What do we do at the University of Virginia? As I said, I did this sabbatical in the late 90s in New Zealand, and came back to UVA, where I had been, in order to start expanding our telepsychiatry and rural mental health care. From 2003 to 2007, our telepsychiatry was done primarily by individual psychiatrists, mostly me, but I had help from a couple of others. We then went into phase 2 in 2008, where it became a PGY4 elective, and I'd have anywhere from 2 to 3 PGY4s, senior psychiatry residents working with me to expand our capabilities to providing telepsychiatry. And then in 2012, because of the increasing demand and the growing interest in doing telepsychiatry, we moved the whole system into our PGY3 training program within our outpatient clinic, so that all of our psychiatry residents now get exposure to doing telepsychiatry. In the initial phases, those first 4 years, I saw 145 initial contacts and 139 follow-ups, so a little less than 300 people. About 150 people, because there are multiple visits for some. Mostly females, average age about 42. Most, as we said, had no insurance. This was before Virginia expanded Medicaid, and all but one was Caucasian. One of the biggest problems we ran into, though, was a very low show rate. Only about a third of our intakes made their appointments, and just over half of our intakes came to follow-up visits. And this was way below what we saw at other clinics of UVA. And the other problem that we ran into was because there was primarily just me doing it, and then later some fourth-year psychiatry residents, the time for follow-up visits grew extremely because there was such a limited number of hours available for doing this. As you can see, that between 2003 and 2004, the time for to have a follow-up visit tripled. In phase two, when I brought in the residents to help me, the fourth-year residents, our average attendance increased so that about 65% of our intakes came for their appointments. And then when we moved it into the outpatient clinic, it dropped down to just above 50%. We've been doing this, though, for about 10 years in the residency clinic. This is looking at the number of contacts. So over a 4-year period, here in 2003 to 2007, when it was primarily my doing it, we saw about 284 people. When we expanded to the residents, helping me, the fourth-year residents, over a 3-year period, we saw a equal number of patients, but over a much shorter period of time. And then when we expanded into the outpatient clinic, in the 1 year alone, we saw far more than we had seen in the other methods. This is looking at our show rate. You can see that it climbed. We had better people coming in this phase two with the psychiatry fourth-year residents, but then it dropped in the first year of being in the outpatient clinic. But what we found, though, was we had two types of connections with the primary care providers in Southwest Virginia. One was the traditional consultation method, where they pick the person to be seen, send them to us remotely, we evaluate them and send back suggestions to them, and that's pretty much where things stop. And if they want us to then see the person again and follow up, they refer them again. We then started building on a collaborative model where our resident became very much of a remote member of the primary care team and worked with them not just in the telepsychiatry sessions, but would answer questions for them and be available for follow-ups. And with this, we saw that we had a much better show rate by using the collaborative method. So we have, over these 10 years, we have pushed more and more to the collaborative method of working with the remote clinics. And now we have a much better show rate. In 2022 alone, just looking at this, we had about 13,000 clinic appointments in this 2022. 3/4 of which were face-to-face, but a quarter of our appointments were remote. And this is looking at comparing our face-to-face with our remotes. We had far more intakes in our face-to-face. The follow-ups, again, were far more. And you see that, again, 3/4 of the patients were face-to-face, but almost a quarter were remote. But if you look at this, no-shows, our no-show rate for our telepsychiatry patients dropped down to just below 3%, which is a third of what it is for the clinic as a whole. So moving to this collaborative method was very productive in allowing people to connect with us and feel more comfortable connecting with us. And this is looking at the percentage per the vehicle. So intakes per just face-to-face visits and intakes per just remote visits. And follow-ups were almost equal. There were more therapy sessions done in our remote than therapy sessions done on our face-to-face clinic, and their no-show rates were about equal. So this is a satisfaction survey that we did a number of years ago when we first started doing the telepsychiatry, and out of 4, most of the people saw our efforts as very helpful. The UVA staff was very helpful. How likely are you to make another appointment? Again, it was very high, so we found that if people came for their initial appointment, then they were much more likely to come for a second visit, and they found the connection very good. How helpful was the appointment? 3.6 out of 4. Are you likely to recommend this service? Again, almost 4. So it became overwhelmingly popular once the people made the connection with us. And these were all held within the primary care offices themselves, which is a very important thing for Central Appalachia and Southwest Virginia. Whereas if you go into the community mental health center in these small towns, probably within an hour or two, everybody in town will know that you've gone into the community mental health center. Whereas if you go into the primary care office for your mental health care, no one knows whether you're going for diabetes or hypertension or just a well visit. And so that made it much easier for people and had much less stigma. How anxious were you before the appointment? 2.7. How anxious were you at the end? It dropped down significantly, a whole point to 1.8. How satisfied? Almost a full 4. And how easy was it for you to make the appointment? 3.28. So we saw initially that we had a very good reception by the local communities. So what have we learned? And we've done a couple of studies that I'll talk about in order to try to understand more of what's going on with these remote connections in Southwest Virginia. And I'm both a psychiatrist and an anthropologist, so some of what the work we've done is not only quantitative, but also qualitative. We've done some ethnographic work in order to try to get a good handle on what's been going on down in Southwest Virginia in relationship to telepsychiatry. 4 things I'm going to talk about briefly. One is their preference for telepsychiatry, which through their questionnaire, which we just saw, was very high. Talk about something I call the trauma paradox. Talk about the importance of the family, and talk about the importance of supporting primary care providers. One thing we've seen is that for these populations, the people of Central Appalachia, our Appalachian cultural population in Southwest Virginia, that meeting over telepsychiatry, meeting remotely, they prefer that over face-to-face visits. It first came out to me when I met with this 75-year-old woman, and usually at the end of the first meeting, I would ask them, well, how was it to talk with me over the television like this? And she thought for a little while, and then she said, well, if anything went wrong, we couldn't hurt each other, which made me sort of step back. We couldn't hurt each other. That means I was in much danger as she was in danger from me. So I had to think about this. So face-to-face connections down there, unless you're really careful and comfortable with the person, often entail an element of potential danger to them. And I can talk about that a bit more if there's questions about it. Another person, a 40-year-old man that I've been working with for a while, said that he's comfortable with me now, but not with other doctors, that he feels judged by other doctors. So he shells up inside and doesn't talk to them when he has to do face-to-face visits with them. But seeing me over the television made it much easier, especially at first. And it would probably be okay to meet with me now, maybe face-to-face, but the TV makes it much easier. And all of this comes down to the cultural concept of bad nerves, which I can talk about if you're interested. So this trauma paradox, what's the role of violence and trauma in this population, and how do we address this through telepsychiatry? One study which we did was doing a chart review of our patients, looking at their diagnosis. And you can see that there's very high rates of depression and affective disorders, and a pretty good rate of substance use disorders, but a shockingly, surprisingly low rate of PTSD. We couldn't understand this because for the rate of known trauma down there is very high. This is looking at the counties in Southwest Virginia based on CDC data versus on the average in the United States. And you can see that in all of these types of mortality, which are not natural causes, so unintentional injuries for males or females, so usually job-related traumas, as well as these other motor vehicle accidents, homicides, firearm homicides, and then suicide. In all of them, the counties in Southwest Virginia have anywhere from 2 to 3 times the rate of mortality compared to the United States as a whole. A study that was done looking at populations impacted by violent crime, the rate in Appalachia is almost over twice the rate of people being impacted by violent crime in Appalachia compared to Virginia as a whole. So there's lots of data suggesting that these populations are very much exposed to lots of trauma and violence throughout their lives. And when we did our chart review, something very interesting came out. So these are people that reported some sort of trauma experience, and 64% of them had PTSD symptoms, whereas 36% didn't have PTSD symptoms. So that makes sense. Not everybody that's exposed to trauma develops PTSD symptoms. But if we looked at people that did not report any trauma, 46% of them, almost half of them, had trauma symptoms. And we worked to try to understand what was going on with this population. And what we realized was that if you asked about trauma in a very general kind of way, saying, well, have you had any bad experiences in your life? Have you been exposed to any kind of trauma? Most people would say no often. But as a consequence, when we went through questions about specific symptoms, they would have PTSD symptoms. So what we realized was that the trauma, the violence is so common down there that they essentially accept it as part of just everyday life down there, and that you have to ask about very specific trauma experiences before you get a history of trauma. That sexual abuse, it has over a third of women express this. A quarter to a third of men and women experience physical abuse. Other sorts of trauma, 63% of men experience other kinds of trauma. So very high rates of trauma exposure. And all sorts of trauma, childhood physical abuse and neglect, sexual abuse, adolescent sexual and physical and emotional abuse, adolescent abuse, prison experiences, gunshot, knife wounds, severe vehicle accidents, work-related trauma, so many traumas in their lives. So what the conclusion from this was that trauma is very common for them. The patients in the area just accept it as part of their life and don't particularly comment on it, even though they may still have trauma-related symptoms. The role of the family is very important. These populations, what are called the Scotch-Irish or the Protestant German populations or the English populations that settled in central Appalachia, were essentially refugees from Europe. And they developed, both in Europe and here in the United States, very strong family connections that are very inwardly focused and provide a strong sense of support for each other. And they see the woman's job in the family as maintaining the strength and integrity of that family, whereas the man's job is to support it financially. And this also means, though, that women are supposed to stand by your man, as the country song says. So even if your man is unemployed or into substance abuse, an alcoholic, or even abusive, nonetheless, you are supposed to stand by your man. And this is very much supported by their religious beliefs. In marriage, though, as a consequence of these clans, when two clans are joined through a marriage relationship, there's often tension then between the two families. But we also have found out that families are a source of drugs within these situations, that the opioid epidemic in this area is not fostered through gangs as it is in inner city areas. The drugs come primarily through family members. And as a consequence of the drug problems, the opioid crisis, many families have become overwhelmed by the mortality and morbidity from this substance use, so that the number of foster children is incredibly high. And so a family that's maintaining their occupations, that's supporting themselves, may suddenly find themselves incorporating the children of siblings or cousins, so that a family of 5 or 6 may suddenly grow into a family of 10 or 12 in one household. This is looking at the source of the pain relief, the narcotics, the over-the-counter narcotics, and you can see the 60% comes from friends and relatives, where only 4% comes from some sort of dealer, and the other part is through doctors. Women, looking at them, are often depressed. There's been high rates of depression in women from our studies, but they don't come forward to talk about it because they're worried about the stigma of it. They will only describe their feelings when it becomes so problematic that they have a breakdown or they're unable to fulfill their family roles. And other family members feel then threatened when the woman in the household is unable to care for them and do what's expected, so that it reverberates to their family. That having to admit distress for them feels like a failure. So that coming into the primary care offices and being seen there, it's much easier for them to talk about these difficulties than if they went to a mental health center. They contain their feelings until they're overwhelmed by their feelings. If they admit their frustration to other family members, they're often shunned. And only when they admit that there's a strain is there any sort of support for them. But it's often at a cost of their then losing self-esteem. It's become very important for us to realize how the primary care providers are central to all of this. Most primary care providers, as you're well aware, have had little or no training in mental health. They see more patients on the average than suburban or urban primary care providers. So therefore they have much less time to work with their patients, and often have to avoid asking mental health questions because they don't want to get into that. They'll open up something that they then can't deal with. But through working with the collaborative care model, we've had a lot of success working with these primary care providers. But we found out that not only working with them ad hoc about specific patients, that they needed a lot of education about mental health care. And so we've developed a very strong ECHO program to educate them about mental health care. And we're starting to expand that into providing e-consult services for them as well. This is looking at our launch of our ECHO programs and giving some of the programs that we've provided throughout Virginia. This is just the advertisement for one on looking at postpartum depression. E-consults, if you know about those, are asynchronous consults where a provider reviews the records and then sends back recommendations. So in conclusion, we lack good epidemiological area for this region. There are small studies that show that there is a great deal of distress and mental health needs. It's important to understand the cultures involved, to understand the expressions that they use, depression, especially the concept of nerves. The depression is very closely tied to family dynamics and gender roles, both positively and negatively. That telepsychiatry has helped to improve mental health care in this area. We've done it by working within the local culture, that the collaborative model is the best way to do this, and that the primary care providers need to be supported through such efforts as ECHO educational models and using e-consult programs. So that's all, and I can stop sharing now. And if you have questions, please bring them forward.
Thank you so much. That was awesome. Yes, everyone, please, if you have any questions, pop them right into the chat. We do have one in the chat currently, so I'll go ahead and read that to you.
Thank you.
Do you use licensed mental health counselors in any of these projects?
Yes and no. Some of the clinics have licensed mental health providers in the clinic itself, some of the larger clinics. And when someone like that is available, uh, that makes everything run so much better because they can often then act as a liaison to us, between us and the primary care providers. But in some of these areas, there's very few, if any, licensed uh, mental health providers. And that's something we would like to start providing. And we've done that a little bit in the clinic. We now have believe it or not, we have a social worker in our mental health clinic at UVA who is starting to provide some of this. So it's not something we've done particularly before, but it's something we're starting to do now. And at our MAT program that we developed near Wise, Southwest Virginia, we have also provided some uh, uh, non-psychiatrist mental health care televideo, but it's not something we are though working. We've done some programs working with peer providers in parts of Southwest Virginia and in over in the Valley in central Western Virginia, western part of Virginia, and that's also a very good technique. And we've worked very closely with these peer providers who provide great help, and we work with them giving psychiatric care to their clients. So the answer is yes and no.
Thank you. Another question is, do you ever partner with local libraries or churches?
Um, in Southwest Virginia, that's a very interesting issue. Um, there's two types of Christian churches in Southwest Virginia. One are the larger uh, disciplines where there are institutional parts, like the Baptist Church or the Presbyterian Church, and it has been possible to connect with some of those. But a great deal of the religious activity in Southwest Virginia is done through very small churches where uh, the people that come to attend that church maybe only 40 or 50 people, and they all may belong to one clan or a couple of close-knit clans. And the minister is usually someone who has just uh, gotten the word from God, from Christ, to become a minister. So they don't have any sort of training particularly. And these churches are very much focused on helping the people gain access to heaven, and are not very focused on dealing with what we might consider more social concerns, and have shown very little interest in joining with us in these kinds of efforts. Some of them have become involved with some drug treatment programs, and we're starting to work with them through that, but they've not been very interested in connecting with us. So there's a little bit of connection there. We have not connected particularly with libraries yet.
Thank you. And then just another question that follows up with that, and it's closely tied to it. Do you engage with any other community-based organizations to assist with social determinants of health?
Um, yes, what part of our large Central Appalachia network is very much focused on not just mental health providers, but we've brought in Appalachian scholars. We are other groups down there. What we found through our time working on these issues is that all these little counties or towns have people that are good Samaritans, are trying to do something to promote care of some sort, either through housing or job employment. And so we're including those in our network too, and trying to build connections so that it's up to this point, it's been primarily people working in their individual little silos, trying to promote some better life for people. And so because of the huge needs, we're seeing that it's very important to reach out to as many people working in these areas as we can. So through that, we're reaching out and trying to start to work with people that are providing housing, people that are providing job employment, other sorts of structural care.
Thank you. And then one other question, what percentage of patients were admitted for inpatient care versus outpatient treatment?
Very few of them have been admitted through the ones we've seen through telepsychiatry, through inpatient. Uh, uh, because of the waiting time and the number of people seeking services, uh, we don't deal in our telepsychiatry with acute care patients. And the doctors and primary care providers, the psychiatric family medicine people down there know fairly well how to deal with acute situations, and they're usually then referred to the local emergency room where they are then evaluated and may or may not be hospitalized. So very few of ours have been hospitalized as a consequence. They're people that are more may be very ill, but they're not in acute distress so much.
And it looks like we have time for one more question. It seems that trust is an element to overcome for effective treatment. How do you manage that?
Oh, that's so important. These people in Central Appalachia do not trust outsiders. They've been exploited by people. They've had politicians come in and make all sorts of promises and then disappear once they're elected. During the boom days of the 1880s through 1920s, the people were deprived of their land, and so they do not trust outsiders at all. And even though I've worked in this area for almost 30 years and have built strong connections with people, I'm still seen as an outsider. But building that trust is so important, and that's a lot of why we try to work with the local populations as much as possible. And that trust is better through the telepsychiatry. That's part of why they feel less threat from me through telepsychiatry than by a face-to-face connection. And we teach our the residents and other people that are working in those situations some of the cultural nuances that they have to be aware of in order to try to build that trust. That it's a very egalitarian society. Uh, there's no big deal that you're a doctor. You have to earn your trust and prestige. So that's no big deal. You're not afforded automatic privilege because you have this. You really have to meet everyone as an equal. Everybody is at the same basis of things, and you have to understand their maybe not trusting you and recognize that, maybe talk about that even. So it takes some time and effort to build trust. The the MAT program that we developed down there, just to real briefly, we had 4 years of funding to develop this program down there. And we thought, well, in the first year, we'll build the connections, get the thing going. Then we'll have a couple of years to get it up and going, and then another year to help them be self-sustaining. And we'll have several good years of data to. It took almost all 4 years in order to get the program going, because one of the big problems was trying to develop the trust of the people in the local community. When we were getting it going, we had the county sheriff come and tell us, "Sir, you ain't putting this in my county. There's no way." And so we had to spend the first 3.5 years building the trust and making the connections, not well only with the providers that we were working with, but the other people in the community. And now it's going well, but it's really run by the local people. We're on we support them and we provide psychiatric assessments for them, but we're still seen as helpful outsiders. Well, thank you, everyone.
Thank
Thank
you.
you very much.
Thank you so much. Thank you for joining us, Dr. Larry. Thank you to all of our participants for listening and sticking with us, and for all of the really awesome questions that were submitted. Like mentioned, I'll follow up with the notes and the recording for everyone. And our next Telehealth Learning Collaborative will be hosted on September, bear with me, 18th from 2 to 3 p.m. And we'll be sure to follow up with all of the details on that.
And Nancy, it's fine to put forward my email address if you like, if people have other questions that we didn't get to.
Perfect. Yes, I'll be sure to add the contact information along with the slides and the recording. So if anyone does have any follow-up, you'll see that with the notes. Thank you again
Thank you, everyone.
for your presentation and for everyone's participation. Have a great afternoon.
Bye-bye.